Hello, my name is Tru Byrnes. I am a clinical nurse leader at Carolina Medical Center in Charlotte, North Carolina. In honor of the World Delirium Awareness 2021, I'd like to share the program that I am piloting on a medical surgical unit using risk stratification strategies to identify and prevent high risk in hospitalized older adults. So what is this delirium prevention initiative included? In 2020, my team and I developed a delirium risk stratification tool. The team consists of advanced practice provider, geriatricians, informatics specialists, clinical nurse specialists across from all specialty, clinical nurse leaders, nursing administrations, occupational therapists, and service line educator. So it took us a little bit to develop this tool, a few months, and then after that we did some test trial on medical surgical unit and neurology as well. And after what we felt like this is a good enough risk factor to keep and which one we should eliminate it. So we end up keeping 37 risk factors, which I found in the literatures. Then I pilot this tool on a medical surgical unit. How do I use this tool? So basically, every day I perform chart audits on patient age 65 and older. Look through the history, the labs, their medications, physical therapy notes. So it's pretty detailed and very time intensive. So after I do that, I calculate a delirium risk score, and this basically it was entered into a database that I created, and basically I just put in the patient risk factor, and at the end it give me a score. So I used to look at this score and then round on the patient with high risk. So high risk meaning patient have 4 or more risk factor, medium risk 2 to 3 risk factor, and then low risk is 0 to 1. And then patient who have positive CAM. So considering if patient have all the feature CAM positive, or patient have either score 1 or 2 feature and they're not fully delirious based on the nursing documentation, I also round on those patients. And then any patient that physician document altered mental status, I also round on those patients to make sure these patients don't have delirium. So what are the intervention consist of? So for those high-risk patients, I implemented the delirium protocol bundle. So this bundle was developed by our team as well. Basically, those are consist of the non-pharmacological nursing interventions. And this protocol is hang on the patient door to alert the staff to say, this patient is high risk. These are the suggestions for nurses to implement. And then I spent an extensive amount of time with the patient and patient family and discuss with them about delirium prevention. If they notice the patient became delirious or confused, please let us know. So the patients and family will watch a video with me about delirium prevention, and this delirium prevention education was developed by our team and got approved by the health literacy committee. So that's how we use it. Then this got embedded into the interactive patient care system, so they can view it from the TV as well as they can actually access it later when they got home. I also look at the medications. So if I found any medication that's suggested for high risk, those medications are anticholinergic, and I will talk with the primary care nurse, ask them to see if they feel comfortable asking the attending to modify or change these medications. And this also giving me an opportunity to educate our nurses about medications. And so next time if they see this same medication, they can advocate for to have it removed. However, if they don't feel comfortable, I typically contact a provider myself. Now, last year I got awarded for a small fund that I used to buy what I call Delirium toolbox. So those included crossword puzzle, coloring books, eyeglasses, game books, pocket amplifier, and harps music. So those are the things that I use for our patients to keep their mind occupied and sharp. And then I also have games for dementia patients. So these games were suggested by our geriatricians. So far, I got a pretty good feedback about this Delirium toolbox. So it's kind of fun for the patients to keep their mind off of things, because in the hospital, 12 hours can go very, very long for some of them. So what did I do with the patient with CAM positive? I typically perform a deep dives into the chart to make sure that we don't miss anything. Like for instance, one time with this patient was so delirious, and I found that this patient had positive U.A. and culture, but they didn't give him any antibiotic, or the antibiotic wasn't treating this particular bug. So I talked to the provider and we got that fixed, and the patient next couple of days he was clear up. So those are the things that I typically do. And in addition to that, we also implemented non-pharmacological nursing intervention. So very similar to the intervention that we use for high risk. This patient also get the delirium bundle protocol hang on the door. Lastly, because we have a lot of non-geriatrician practice in our hospital, so our geriatrician last year developed the delirium management order set to help guide the non-geriatrician provider how to treat and manage delirium. So this got implemented last year at our hospital, so it's a big win for us. And then we also have geriatric psychiatry, neurology as a consult service. What I have seen were that geriatrics seem to be very popular amongst our attending to consult if the patient happened to have delirium. So currently, I look at the 3 months data with about 225 patients or 250 something. I noticed that we have a reduction in length of stay of 1.7 days for a patient who has delirium compared to our baseline data in 2019. And then we also have an increase in detection rate by 50%. So this was something that I did mention to the nursing administration team, that they might see the rate go up before it go down, because nursing was under-recognized delirium. But because we were able to identify it early, their delirium duration a lot shorter, so that it was able to, that's why we see in reduction in length of stay, because they was able to get home sooner. Now, the reduce in discharge to post-acute care facility by 18%, meaning that these patients, they went home instead of going to a skilled nursing facility. So this project is still ongoing. I'm hoping to get more data sometime mid-year in the third quarter. So my next steps, I am working with a team, informatics specialists, to try to get this tool embedded into electronic health record. So that way we can identify patient at the point of entry. We are in the process of transition into a different health electronic health system. So with that, hopefully we'll get this pass. And then the delirium protocol, nursing delirium prevention protocol, I hope to get this embedded into electronic health record as well. So everything will be computerized, and that this will take less time for nurses to do on the audit piece. So right now I spend most of my day doing auditing and then rounding. However, if these tools get implemented into the computer, I'd be able to just pull the report and see who's high risk and round this patient instead of doing the audit myself. Delirium education is a must. I feel that nurses should be proficient in delirium assessment and preventions. So that is I hope it's going to be a requirement for us at our facility as a yearly competency. And then having delirium champions on each unit to help with identifying and preventing delirium in hospitalized older adults, and have these champions rounds on those patients. And I feel like having a consultation services such as geriatric neurology and psychiatry, those are really, really, really important, because nurses, we can do a lot of things intervention wise, but when it's come into like complexity, if the patient have some other underlying issue like stroke or having multiple polypharmacy, so our geriatrician do a great work on medication reconciliations. So we are very blessed to have all these services at our facility. So thank you for watching my video. And if you have any questions or more detail, please don't hesitate to reach out to me. And thank you, American Delirium Society, for put together this wonderful marchathon. Thank you.